Good morning, Jens. Good morning, team. Thank you again to Seattle Science Foundation I'm honored to be involved. So we have an amazing group of team players here. We have Nathan Pratt, our erstwhile and intrepid spine fellow at SSF, and I'm joined by Nick from Globus, and of course Gary and his team, and everybody's here. So we're excited to demonstrate to you robotics. So what I thought we could do was talk very briefly about the robot, its role, and then get on with demonstrating instrumentation, as time permits, some of the additional capacities of this enabling technology, such as interbody software and so on. So basically, my talk later today is why do we introduce robotics into our surgical practice? But in brief here, you'll see that I'm not wearing lead. I hate radiation. It's been a feature of our lives as spine surgeons, those of us who trained under fluoro, and then navigation with, say, O-arm and stealth came into the field, reduced a little bit. We're at the point now where we could reduce radiation a lot. The next big thing is, of course, accuracy, and I think, there's a lot of data that shows that robotics has equivalent, if not better, accuracy with respect to screw placement and reliability as well. So, and finally, I want to kind of emphasize, and we'll do that in the talk, as to what it isn't yet. It is not an automated machine that does the drilling for you and puts the instrumentation in for you. So you still need to be a surgeon, and the capacity that you have here with respect to judgment, particularly when it comes to skiving, placement, preoperative planning, allocation of instrumentation so that it makes your life easier, for example, with rod placement and so on. All of that is still needed. So technology improves, but at this point, we still need our own intrinsic understanding to make that technology work. Okay, so Nathan and I are going to demonstrate. This is the Globus Excelsius robot. I use it. I have capacity with respect to placement of screws, and of course then interbody navigation, which helps to place the interbody in. We do a lot of our lateral work. We use the lateral navigation software. We have the patient in our prone position, and we use that a lot, again, to minimize the impact of X-ray and hopefully get a good result with our lateral implants and so on. So we want to just kind of start with posterior instrumentation. So just to demonstrate to you, we've planned out screw instrumentation for 3, 4, and 5. You can kind of see that there ahead of time. And I have deliberately placed one of the heads of the screws a little bit more medial. So in my preoperative planning, as I place screws and I kind of make a decision as to, for example, here's the left L3 screw, and you can see it kind of outlined here. Let's say that this screw is a little bit too medial for my placement of a rod. I'm able to alter screw placement, and you can see the corresponding position of the screw head on the kind of the overlaid view of the instrumentation on the X-ray, and work it so that it's beneficial with respect to what I need to do. So I'm able to rotate and translate the screw. I can bring the screw in and out. I can lengthen the screw. I have the ability to change the diameter. We've picked a 6.5. I can change the length, for example, to a 40, 45, and so on. So preoperative planning is such an important part of this, and that doesn't change whether you're doing, fluoroscopy, CT navigation, or robotics. So, okay, so we're ready to proceed. This is the end effector part of the robot. This is the monitor, obviously. We have a dynamic reference base, which is like the radar with respect to the camera. So it communicates, triangulates between the end effector, the DRB or reference frame, and the camera, which is up here. And then this is a surveillance marker, which looks specifically at kind of shift motion with respect to what's happening to the patient. For example, if we're leaning on the skin too much or moving the patient in an awkward position, there's a guide here, a force guide and a surveillance guide which reflects shift that tells us the amount of force and translation applied to the patient when we're putting in instrumentation. Basically, it's like an accuracy check. So let's start with L3 on the left. So it's pedal driven. You can see I'm going to start to plan my instrumentation, and it'll guide me as to where the screw placement will be. Like all robotics, there is a line of sight component to it. And when you see the green outline, that's an indicator of the fact that it's on target and in position. So I kind of just use the marking pen to guide me there. Same with 4. So we'll do one side at a time. So this again, it's basically a assistive arm for guidance. It's a guidance-based arm with an accurate trajectory. And again, I'm able to kind of mark it out. We'll just do L5 as well in case there's time. But these have been pre-planned screws. And as you saw previously, I'm able to change the trajectory of the screw as I need to. Like everything with robotics, the setup is obviously a little bit of the time suck when it comes to the workflow. But the workflow that we have here is that we've acquired a preoperative CT scan beforehand, and we've taken 2D images with fluoroscopy, and those two have been merged here. And so what you're seeing is a merge between the X-rays through fluoroscopy and a pre-op CT to give us this level of accuracy. Okay, so let's go to right side. I'm going to hand this to Nathan.
Thank you.
And Nathan, before we do that, let me just mark out on the skin. So this is, for example, where I want to, let's do 3-4. We're going to kind of do 3-4 initially for the purpose of time. As we have time, we can extend up to, but I can mark out on the skin. So Nathan's going to do 3-4. To save time, I'm going to, and this is my workflow as well, once I put local anesthetic in the patient, I'm either able to do stab incisions here for true percutaneous screws, but obviously when we have 2 screws close together, the incisions merge together. So I just do the one incision here. I do a little bit of a bigger incision for allowing the rod placement. So there's your 4 coming into view. Appears slow a little bit. I think the upgraded software is much faster with respect to certain motions for the robot. And there you are. And then if we need to get the robot out of the way, I just deselect the screw. There's a collar which I'm able to move out of the way. And we can kind of get to work. I typically like to go through the fascia. Don't have a bovie around, but the knife typically will let me do that. Here you are.
Thank you.
So I'm going to start with my screw, left L3, and then make it a little bit longer, Nathan, the incision, just for the purpose of the screw. Yeah. That's it. That's great. And you may go through that superficial and deep layer of the lumbodorsal fascia.
Yeah, I think
great. Okay. So again, at this point, I'm able to have the robot bring me to trajectory. And again, this is faster in real life because of the software upgrade for clinical. So I'm on target there. It tells me that I'm on target here. Now, if I wanted to remain on target, and let's say it was a particularly big patient, and the end of the end effector was either in the skin as what you'd find with, for example, an SI joint fusion, which is, I found this to be ideal. I'm able to bring this up and down in line, as you can see, in line with that trajectory. And the yellow just tells me that I'm not on target with respect to the screw. So if I press that, it'll make that correction for me. Or it should make that correction for me. We may come back to the screw. Again, it's all drill pedal. It's pedal based here, so it's easy. I don't need to touch anything. That can happen off the field too. The rep can do that. Okay, perfect. We have green. So here we go. So long knife down onto the bony elements. Typically, there may be a small bleeder here at this point. I'll take a high-speed burr. So again, this is the tracker for it. I typically come down, thanks, onto the bone. You can see that there. Occasionally, I may need to do a slight micro adjustment. And it's interesting, as you rotate the array, for reasons that we've discussed at these courses before with respect to navigation, there can be a slight difference there. But I will accept that level of accuracy. Come off a millimeter, and then I'm onto the bone. I'm making my pilot hole there. Here's my drill. This drill will take me 30 millimeters. It'll take me down to the, into the pedicle and beyond. So I can depress the pedal. It'll make that slight adjustment. If you have a look, you can see the slight correction of the trajectory. Again, and part of the reason why is because, so if you let go now, it should be more accurate. There it is there. Again, that shift that I was talking about is an issue. So if you see and that's the maxed out length of where the drill will take me. And the next step for me is literally the screw. Now I have the option of tapping, and that can be navigated too. Again, I'm able to make that micro adjustment with the, so if you let go of the finger, yeah, there you go.
Sorry,
yeah, no. Nathan is being extra helpful. Purely for, yeah, and now you should be good, yeah. So you can see that I'm able to pretty accurately place my screw. If I change the array, for reasons that we've talked about, and there is a check mark that occurs. Not getting it here because there's slight translation between the projected plan on the axial, but that is acceptable for me, and I know based on the feel of the screw that that's pretty good. So then I'm able to back it out. If I have difficulty backing out, I'm able to just undo one turn, and that'll let me bring the driver out. Okay, so let's go to you, Nathan. Okay. So right L3. This is the part that I love is the ability of the robot to keep to target and keep to plan. And if there is a shift or excessive pressure that's applied, then there's a meter or metric for that. Yeah. Slight adjustment. You have this, you can even extend the incision if you want a little bit, and that's what it lets you do. Perfect. I'll make it easier. So this is a point I want to make. Robotics, and we'll get this in the lecture, it's not about MIS with respect to MIS being a skin incision. That is not the goal. I don't believe that's the goal of MIS, and it's not the goal of the robot. What MIS is for me is reduction of the physical burden when it comes to, and there you go, perfect. So you're onto the bone there. Make a micro adjustment, slight medial, that's it, perfect. And then you can back off a millimeter and come straight onto the bone. So it's really reduction of the physical burden on the patient with respect to soft tissue dissection and so on. And I think that's the value of robotics here. Often my incisions are the same,
I'll use the tap on this side.
And maybe even slightly larger compared to if I used K-wire and X-ray. But the benefits are, of course, the accuracy, the increased trajectory. So again, same deal. Make a slight, yep, there's a micro adjustment. And then onto the bone, all the way down the pedicle until you maxed out, and you can see the flange there. So he's maxed out. And now Nathan's ready for the screw.
Do you want me to demo the tap or just do the screw?
Yeah, why don't you demo the tap? Perfect.
Tap.
Yeah.
I mean, it's nothing special, but.
So obviously, with our so-called cortical screws here, where you're going through cortical bone, it's an advantage to tap that bone, either to size, and then ultimately place these medial to lateral, inferior to superior cortical screws, which this isn't, but that's another added value of using robotics. Okay. Very good. And again, I just redisplay the pedal there. So just hide your instrumentation for 1 second. Yep. Yeah. And the goal really is, yep, we have the green there, so you're ready to proceed. As I was saying, the main value of robotics here, of course, is the fact that you have navigation. It is navigation. Robotics is navigation. But it's reducing that cognitive load on the patient and the physical load, cognitive load on the surgeon and physical load on the patient with respect to corridors of access. And in so doing, improving the outcome, which we have plenty of data for in the literature with respect to minimally invasive surgery. It is not about the incision. Sometimes it's not necessarily about the dissection. There we go, perfect. When I do a T10 to pelvis, it is a significant reduction in my cognitive load, and over time, so he's demonstrating a nice little kind of troubleshooting. So here you can back off the screw by a little bit.
Okay.
That's it. And then you always have the ability to re-drive that screw down later. So in this situation, yep.
There it is.
He was able to do it. If he wasn't, then we could just take the end effector off, and it makes it so simple. So go ahead. So with this workflow, I like to place screw on one side and snake down, so the next screw will still be on Nathan's side.
Okay.
So let's go right L4. And he hasn't driven the screw down so tightly that the tower is stuck to the bone, and which would make it difficult for manipulation of the tower. But again, we're on target, which is great.
Hey, Noosh, got a question. So first of all, this is very nicely demonstrated. I have a practical question, then a big picture question.
Yeah.
How much longer do you think you'll need for your presentation here to get your
Okay.
No, just roughly, hint,
Yeah.
hint, hint.
Yeah, I mean, really the goal was just to demonstrate screw placement. We don't need to place rods. I think, you know, Jens, I just want to show the interbody software only, so maybe another 5 minutes.
Yeah, so one question then about technique. Can you show or try to show what happens if you have a skiving event? So this is a very important safety feature that I think is a technological breakthrough.
I'm sorry.
Would you also try to see or show how the skiving prevention works?
Yes, exactly. Excellent point. So, so let's demonstrate it on here. So for example, you can see that the screw head is coming down the superior articular process of that level below, and it's in an awkward angle. If that's the case, let's say I'm just not happy with that placement, and I think this isn't bad necessarily, then I can go back to my original plan. It's the right L4 screw. So Jens, I'm able to translate it and seat the head of the screw in a more, if you like, safe position, as opposed to, let's say that we had this situation here, where my screw head, and I don't know how well you can see it, is really on the cusp of that superior articular process coming down the mountain, if you like, onto the TP. And that wouldn't be an acceptable position. It's a simple change for me to make an alteration of the instrumentation. So I'm able to easily do that, make that correction. And then, you know, you can kind of see it. That here we are. This is my ideal projection. I'm seating it in my ideal spot. Now, this is an easy cadaver because their anatomy has read the textbook. But if that wasn't the case, and then all I need to do is just reapply my pedal, if you like, and you look at the micro motions that are present there. The other aspect to your question, the other answer to your question with skiving is that, and that is the reason we use the high-speed burr, is that we need to place the pilot hole in the right spot, because each subsequent instrument will tend to follow the trajectory or the track of the pilot hole. So the pilot hole matters. So you can be judicious about it. The tube itself is rigid, and it's really intended for a direct placement of the burr, the drill, and the screw, but it does allow for some micro motion. I've talked about the micro motion, micro adjustment. So I can look at the screen, believe the image or not, and if I find, for example, that I'm skiving constantly, replan the screw to avoid that trajectory and hopefully achieve my goal. So, yeah.
Hey, it's Roger Hartle. Can I ask a question?
Yes, go ahead.
Hey, I really like your presentation. I came in a little bit later, but that goes back to Jens's question, because I do a lot of navigation. I don't use the robot. I've done a few cases with the robot. My biggest criticism is with the robot is the lack of tactile feedback, especially with skiving, right? Like, for example, like right here, what you're seeing right here, you're a little bit high in that pedicle. So if I did a freehand navigation case, I would compensate. I could look. I get the tactile feedback. I compensate on the screen, and I would direct the screw a little bit lower down. But I get that tactile feedback always, all the time, and I think that's really important with navigation. Yeah. With robotic surgery, you're totally losing that. So you really need something that's like 150% safe when it comes to skiving protection. And I'm just wondering if that high-speed drill that you're mentioning, is that really good enough to always make sure that you're really getting into that trajectory?
I completely agree with your point. I slightly disagree with your solution. I think that tactile feedback is so important, as you know here. But I'm still getting tactile feedback. So if for those of us that have done a lot of robotics and we're past that learning curve, we are able to, once I trust the navigation, it really matters that the registration's accurate and it makes sense. I actually don't constantly look at the screen. I use the tactile feedback from the instrumentation that I'm placing to guide me. To the point that, on the flip side, when I've lost that tactical feedback while putting a screw or an instrument down the end effector of the robot, I disbelieve it. I check again on the trajectory. I re-register my trajectory with the foot pedal. And if it's still not adequate or accurate for me, I replan the screw into a better position. And I think that the slight advantage of that is that compared to fluoro or a non-navigation-based solution where I'm pockmarking a lot of potential different pilot holes, and I've done this so many times, here I'm minimizing the number of pilot holes that I make based on a trajectory that I believe. And hopefully that means minimizing the skiving. But you're absolutely right. I mean, the tactical feedback is critical. So a robot is not, and I just want to emphasize this, it's just an assistive arm. It is there, it's a guidance tube. It is not self-automated, it's not a self-drilling, not a self-placing instrument, or at least not yet. You need the surgeon. It is not the surgeon. And we'll talk about that later today.
Great. Okay, any other concluding statements? Yeah,
so just last thing, Jens, when it comes to interbodies, and I think this is, we talk about the fact that, well, where's the robot going? And I'll talk about that. Here's one additional capacity that is developed over time. I'm able, for example, to take my interbody placement here in 3/4, and you can see this, and basically select that instrument and drop it down and place my interbody cage into the spot that I want. And what that does for me, obviously, is two things. Is that it provides a pathway for navigation, not robotics, but navigation for that interbody, and it minimizes X-ray. It's one step where I can minimize the impact of X-ray on my body. And as I age, as we all age, we want to reduce the radiation. I know Paul Park and others don't even wear lead. I have drastically cut down the use of lead. And for my final shot, it's me stepping away 6 feet and behind and looking at the final pictures as a verification. So I've minimized the use of lead in my cases. Thanks.
Which is great, and we'll have to discuss more later during your lecture, which we anticipated. It was nice to see this live, and again, thank you for taking the time to come here and show us how to do this and how to do it right. And just want to point out one quick question, maybe you can answer that. So you have less radiation for yourself and the OR team. For the patient, this means that we have to have a fine-cut CT scan despite dose reduction protocols. This is at least a 2 millimeter, but usually less than 2 millimeter protocol with cut density. So is this an increased radiation burden for the patient?
Yeah, it's such a good point. Yeah, naturally, obviously, you know, like you said, they're fine cuts, 1 millimeter preferred or less. So it's more than your standard 20 milligrave radiation. But what it means is that compared to, I just get the one preoperative CT that has that now, compared to before where I would get a preoperative CT to look at the bony anatomy, and then I would maybe get an O-arm spin in the OR, and I'd bring C-arm in and take a bunch of fluoro shots. Let's say PERC, I'm using, K-wire and Jamshidi needle. So I don't have the data for you, Jens, but I believe it's out there. But in my anecdotal practice, that is less, I believe, radiation. Yes, it's more because of the initial outlay of the fine-cut CT scan, but I'm avoiding an additional CT scan, whether it be intraop or as part of preoperative planning before the surgery. So.
Great point. Thank you, Noojan. Again, to be continued later during your lecture. So get ready for more questions. But great stuff. Time out.